Assalamu alaikum wa rahmatullahi wa barakatuh. Today we'll be discussing hypothyroidism, and we'll start by review of the thyroid gland anatomy. The thyroid gland, as you can see here, is situated in the front of the neck, in front of the trachea, and it is composed of two lobes, right lobe and left lobe, and joined by an isthmus. The gland is consisting of multiple thyroid follicles. Each follicle is actually a group of cells, the follicular cells, which secretes T4 and to lesser degree T3, stored in the center of the gland with what we call the thyroid globulin. This is a glycoprotein, a storage material for the thyroid hormones. We can see here the thyroid hormone production consisting of iodinization of tyrosine, the amino acid, to diiodothyronine. Two molecules are joined together forming tetrahydrotyrosine, abbreviated usually as T4. In several tissues like the liver, the muscle, the heart, and the kidney, there is a monodeioxygenase enzyme which will remove one iodine atom from tetraiodotyrosine, producing triiodothyronine, or what we abbreviate as T3. The majority of the T3 in the blood is formed in the peripheral tissues from the T4. So the secretion of the thyroid gland is mainly T4 and a little of T3. The T4 and T3 is carried in the bloodstream to different tissues over the what we call the thyroxine-binding globulin. The free fraction of the thyroid hormones is the only active part. So almost 99% of the thyroid hormones are combined with the thyroid binding globulin as a storage amount of the hormones, and only about 1% is active on the tissues. As regards the thyroid function, the thyroid hormones increase metabolic rate and increasing the oxygen consumption and heat production. They are absolutely necessary for normal brain maturation, usually occurring in the first 2 years of life, and are essential for the normal menstrual cycles. Thyroid hormones also accelerate the cholesterol clearance from the plasma. Thyroid hormones also are required for conversion of the carotene to vitamin A. And the last thing, thyroid hormones increase the heart rate and the cardiac contractility, what we call the positive inotropic and chronotropic effect. All these effects of the thyroid hormones will notice its opposite as a symptoms of hypothyroidism later on. Now, as regards the causes of hypothyroidism, we have broad categories. The first is the autoimmune etiology. The most common cause here is Hashimoto's thyroiditis, in which there is antibodies formed against the thyroid gland, destructing it, resulting in hypothyroidism. The second is the spontaneous trophic hypothyroidism, resulting also in damage to the thyroid gland. Then we have Graves' disease with TSH receptor blocking antibodies. This means simply that the classical Graves' disease has TSH receptor stimulating antibodies. It is simulating the action of the TSH resulting in hyperthyroidism. But there is a subgroup of Graves' disease with blocking antibodies, not stimulating antibodies, resulting in hypothyroidism. The second group is the iatrogenic. Iatrogenic meaning it is medically induced. So it can complicate treatment with radioactive iodine ablation for the thyroid gland in cases of hyperthyroidism. It can complicate thyroidectomy, of course, after some years, and then with drugs if given an overdose, like carbimazole and propylthyroxine used for treatment of the hyperthyroidism, and amiodarone, the very common used nowadays anti-arrhythmic drug. And the last is the lithium, used in cases of manic depressive psychosis, which can result in hypothyroidism. We have group which is important to recognize. This is a transient thyroiditis. Transient meaning the hypothyroidism here is a phase of the disease. It does not result in permanent damage, so it does not need treatment for life, as we have to do for Hashimoto's thyroiditis, hypothyroidism, for example. We have two examples here, what we call the subacute or the Quervian thyroiditis, in which there is a sort of viral inflammation of the gland inducing pain. The patient passing into first hyperthyroid phase due to release of the thyroid hormones in the blood. Then the thyroid function become suppressed after these thyroid hormones are released, consumed, and no production for them for some time. So the patient passes into hypothyroid phase. At this time, we need to give replacement therapy with thyroid hormones, but not for life, because the recovery happens after 3 to 6 months and patient go back to normal thyroid function. The other cause is the postpartum thyroiditis, which is also a transient cause. It is important to recognize these two causes since the treatment here is transient and not for life. How to recognize? It is very simple. Doing a radioactive iodine scan of the thyroid gland in cases of subacute thyroiditis or postpartum thyroiditis, the intake will be decreased. Now, about some rare causes inducing hypothyroidism. Iodine deficiency in areas dominated by mountains, because there is no iodine in the soil, and congenital hypothyroidism. In this hormonogenesis or in thyroid aplasia, the patient or the baby here is born with congenital hypothyroidism. This is very dangerous. Why? Because as we said in the function of the thyroid, it is important, it is essential for the maturation of the brain. If this congenital hypothyroidism is not recognized at birth or shortly after, and the replacement thyroid hormones are given to the baby, no maturation of the brain, the patient will develop permanent mental retardation in addition to other features of the hypothyroidism. That's why usually in developed countries, soon after birth, sample of the blood is taken for thyroid hormone detection and the TSH level to detect congenital cases and to be treated as soon as possible. The other root cause is infiltrative, like in amyloidosis, inherited thyroiditis, and sarcoidosis. And the last group is the secondary hypothyroidism, secondary to pituitary gland failure. As we said, thyroid gland is under control of the TSH, thyroid releasing hormone, from the anterior pituitary. If the pituitary gland fails, then no TSH and no thyroid function. It will go to hypothyroidism. It's important to recognize, since in cases of hypopituitarism, we have to correct for other hormones deficiency, especially cortisol. And usually we have to replace cortisol first, then we can later on replace the thyroid gland, not the opposite. As giving thyroid hormone first can precipitate acute adrenocortical failure. Now, as the clinical features, usually we are dividing into common features or common symptoms like weight gain, cold intolerance, fatigue, somnolence, tendency to sleep more than usual, dry skin and dry hair, menorrhagia. Signs here, the most common sign is having increase of the body weight. Patient is gaining weight even with trying to decrease the intake of food. The less common and very non-specific symptoms include constipation, hoarseness of voice, carpal tunnel syndrome, in which the patient come complaining of paresthesia or numbness of the lateral 3.5 fingers due to mucopolysaccharide precipitating in the carpal tunnel, compressing the radial nerve. Alopecia, generalized aches and pains, muscle stiffness, deafness, depression, infertility. Usually we see these symptoms in severe cases because most of them are related to deposition of mucopolysaccharides in different parts of the body. For example, the deafness here due to precipitation of mucopolysaccharide over the ossicles of the middle ear. As for the less common signs, which also needs a severe condition of hypothyroidism, the hoarseness of voice associated with mucopolysaccharide precipitation over the vocal cords, the malar flush. Periorbital edema is important here, since usually when we see periorbital edema, we think first kidney problem, nephrotic syndrome. Don't forget thyroid hormones deficiency as a possible cause. Loss of the lateral eyebrows, which is very characteristic. Presence of anemia, usually macrocytic, and carotenemia, bradycardia and hypertension. Delayed relaxation of the deep tendon reflexes. Dermal myxedema precipitation, especially in the pretibial area. This is the classical features or the classical features of the hypothyroidism. The apathetic look, the absent lateral third of the eyebrow, the preorbital edema, the dry skin and dry hair. All this very characteristic, but usually not seen in mild cases. So should have a high degree of suspicion to recognize non-specific symptoms and test for thyroid function. As for diagnosis, as most common cause is the primary thyroid failure, we got here TSH level, which will be elevated, usually above 20 micro international unit per liter. Usually the usual range up to 4.6 micro international unit per liter. So here it is elevated more than 20 because, as we said before, the thyroid hormones are having a negative feedback effect on the TSH. If they are decreasing due to failure of the thyroid gland, then TSH will be raised, trying to stimulate the gland more. And of course, T4 and T3 will be suppressed below the normal reference range. Now, as to the treatment, here we give what we call the replacement therapy. We are replacing the missed thyroid hormones. Usually giving T4 or levothyroxine, starting with a dose of about 50 microgram per day. We'll go for 3 weeks. We have to go gradual. Then after 3 weeks, we increase the dose to 100 microgram per day. We are trying to suppress the TSH back to its normal range, which will indicate that the replacement dose was sufficient. Very important to notice here, since the thyroid hormones have lifetime of about 7 days, 2 things. The replacement dose should be given as a single dose. The check on the TSH should be after 6 weeks. It will take that long after starting treatment or after changing the dose to affect the TSH level so that we can judge if the dose is optimal or not. As we can see here, this is the same patient we've seen before with the classical hypothyroid features with the treatment with replacement therapy. Marked difference. The apathetic look is absent. The patient looks more conscious, if we can say, and the dry skin and dry hair all absent. Marked improvement with the replacement therapy here. Now, we have 2 special circumstances important to remember. The first is the presence of ischemic heart disease in the hypothyroid patient. If it is present, remember we said that thyroid hormones will increase the heart rate and increase the contractility of the cardiac muscle, which can precipitate anginal attacks or myocardial infarction or dangerous arrhythmia, and some recorded cases of death due to too rapid correction of the hypothyroidism. That's why we start with a smaller dose, only 25 microgram per day, and also the increment should be no more than 25 every 3 or 4 weeks, observing any symptoms of ischemia developing in the patient, observing his ECG for any complication. The other special circumstances during pregnancy, as the requirement for thyroid hormones is increased during pregnancy. So we are checking on the thyroid hormones and the TSH in the first, second, and third trimester, increasing the dose still to correct the TSH back to the normal reference range. The last thing to discuss today is about subclinical hypothyroidism. Subclinical in general means that there is no symptoms, but there is a lab abnormality. Here we'll find the TSH is raised and the T3 and the T4 is within the normal reference range, usually in the lower part, but still normal. Usually we do not start treatment here unless we have one of two conditions. The first is having the positive autoantibodies like anti-peroxidase enzyme in the blood. Having these antibodies positive indicating we have an autoimmune etiology, meaning it will go on, it will damage the gland more and will be transferred into an overt hypothyroidism. So we start the treatment. The other condition is if the TSH greater than 10 micro international unit per liter, indicating a severe damage to the thyroid gland already done. Even without symptoms, here would start the treatment. As usual, treatment here in primary hypothyroidism, excluding the transient cause we discussed, should be for life. Since this is a replacement therapy, it is not curative for the thyroid gland, but it is replacing the thyroid hormones, so it has to go for life. This concludes our discussion for today about hypothyroidism. I hope the explanation was clear. If there is any questions, don't hesitate to put it in the comment. If you like the lecture, find it is useful for you, don't forget to share it to other colleagues. Don't forget to comment and like it. If not already subscribing to the channel, don't forget to subscribe and activate the bell button to get notifications of upcoming lectures. Thank you very much for your attention. I hope I'll be seeing you again in the coming up lectures. Wassalamu alaikum wa rahmatullahi wa barakatuh.